Hi, everybody. My name is Nate Rumpf. At the time of this recording, I'm a second year emergency resident at West Virginia University. I'd like to welcome you to this brief presentation series I've made on the basics of mechanical ventilation. Throughout medical school and residency, I've found ventilators and patients on a ventilator to be fascinating. It's also been intimidating, though. I've wanted to learn the basics of managing these patients, but it was overwhelming and I wasn't exactly sure where to start. I'm still not an expert in this topic. However, I found some really valuable resources, and by studying these, I've really improved my knowledge as well as my confidence. I'm hopeful that with this short series, you'll be able to do the same and build on the knowledge that you already have. I've tried to keep the material as short and as applicable as possible so that it is memorable and that you can just remember the key points that are going to help you best care for your patients. If you were to poll a group of emergency doctors on the most common indications in the emergency department for intubation and mechanical ventilation, I suspect that mental status or airway protection would be one of the first answers that you would hear. I couldn't actually find a study comparing indications for intubation in the ED and the frequency. However, at least in my short experience, I've probably intubated more people for mental status than anything else. And this category of patients can really span a broad range. It can be anything from a severely intoxicated, otherwise healthy college student, all the way to a encephalopathic patient with severe sepsis and hypotension and many other things. In this case, we're going to use the simplest scenario, which is an otherwise healthy patient intubated purely for mental status. And I think it's helpful to start here because this gives us a case where we can focus on just the basics of ventilation, like ventilator modes, parameters, and settings, without having to worry about complicating physiology or other nuances that other patients might require. And this is going to give us a foundation that we can then build upon. And in the next presentation, we'll talk about a couple specific scenarios which are a bit more complex. So with that said, we'll go through our objectives. And for this session, there's really only two. So our first objective is for you to be able to identify the key parameters that you're going to need to mechanically ventilate a patient using assist control or SIMV. And we'll go through these modes in more detail later. I'll also mention here that throughout these presentations, we will refer to assist control and volume control somewhat interchangeably. Objective two is to then take these parameters and choose the specific settings that are going to let us adequately oxygenate and ventilate a patient intubated purely for airway protection or mental status. So now that we've covered these objectives, we'll get into it. And we're going to start with ventilator modes. So ventilator modes are complicated enough, and I think it's only worsened by the fact that each manufacturer has their own unique name for modes. Many of these modes are essentially the same or very close, but the names may be pretty different from each other. And this can make it really difficult to remember what is what. In my mind, I need to keep it simple. I think there's a couple modes that are most relevant to the emergency doctor, and that would be assist control and synchronized intermittent mandatory ventilation. And both of these modes can be set based using volume or pressure, but for our purposes, we're going to focus on volume here. So what do these modes do? So both of them provide breaths at a predetermined volume and at a set rate, and they both allow the patient to initiate breaths. If you ventilate a patient with assist control volume, and let's say you're doing it at a rate of 15 and a tidal volume of 500 milliliters, this means that every 4 seconds, the patient is going to receive a breath of 500 milliliters. If the patient is triggering breaths, the ventilator is going to detect it and it's going to support that breath and get it all the way up to that 500 milliliter tidal volume. Let's say we take the same patient and we switch the mode to SIMV. We're going to keep the respiratory rate and the tidal volume the same. So if this patient is triggering no breaths, let's say immediately after intubation when they're still paralyzed, it's going to behave just like assist control. The ventilator is going to deliver that tidal volume every 4 seconds. If the patient starts waking up, though, and triggering breaths on their own, the ventilator is going to do its best to try to synchronize these breaths with the patient. And that means that if it's about time for a breath to be delivered and the patient delivers one, the ventilator is going to assist the patient and get that tidal volume all the way up to the preset 500. However, if it's not time for a breath and the patient triggers one, the ventilator is going to give a little assistance and it's going to allow the patient to take the breath, but it's not going to necessarily reach the full tidal volume unless the patient does that on their own. And you can see in this picture that we have here. So first is a example of assist control. And you can see this first breath is performed entirely by the machine and it's going all the way up to 500 ml. And then the second two are patient initiated, and you can tell by the little negative deflection here at the beginning. And the ventilator still assists them all the way up to 500. Now, SIMV over here, you can see this first breath, no trigger. So that's 500 entirely done by the machine. And then the second breath, so in this case, it's triggered by the patient, but not yet time for another breath. So the machine provides a little bit of assistance and lets the patient take that breath, but not necessarily up to the full 500. And so just an anecdote here, this is something that Dr. Kiefer shared with me that I think is a helpful point to remember. So during his residency, when he was a senior um, about to start ICU, they took a prep course, and part of this was related to ventilators. And a respiratory therapist would actually hook them up to a vent and let them experience some of the different modes and understand triggers and patient comfort and all. And he was explaining to me that assist control was particularly uncomfortable. And this is because anytime the ventilator thought that you were taking a breath, and this could often be mistaken just by movements of your lips or anything else that would trigger it, a full volume breath is forced in. This can be pretty unpleasant for the patient. If they're not intending to trigger a breath and the machine is continually forcing them in, that could be a pretty disruptive thing. And in the emergency department, where patients are pretty early in their course, we're still finding an optimal plane of sedation for them. I think it is worthwhile to consider SIMV over assist control here. This is a way that we can potentially minimize patients' discomfort and also reduce danger with barotrauma and resulting pneumothorax by rapidly triggering full tidal volume breaths and potentially an undersedated patient. That said, volume control or assist control is still an option, but just a point to consider. So now we'll talk about our ventilatory parameters a bit. So you've selected your ventilator mode, and in either mode, you're now going to set your parameters, and they both require the same ones. So they are FiO2, positive end expiratory pressure, which is commonly referred to as PEEP, respiratory rate, and then your tidal volume. In my mind, I kind of separate these into two categories. So there's the factors that affect oxygenation more, and that would be your FiO2 and your PEEP. And then your respiratory rate and your tidal volume tend to affect your ventilatory status more. So we're going to talk about each of these separately. So for oxygenation parameters, so let's say you've intubated your patient. It probably makes sense to set your FiO2 initially to 100%. And that's because during your intubation, you've had some degree of apnea, and your patient has probably experienced some amount of hypoxia during the procedure. So we're going to try to help them correct for that. Once that is done, you're going to be able to titrate your FiO2 down based on your patient's oxygen saturations. And in this patient who doesn't have underlying pulmonary disease, hopefully you're going to be able to get to a pretty low FiO2 and do that reasonably quickly. Now for your PEEP, you're going to have to give at least a small amount of PEEP here to overcome the added airway resistance from your ET tube, but you shouldn't be needing a whole lot here either. For a patient who has no other pathology, only mental status, I think 5 centimeters of water is a pretty reasonable place to start with your PEEP. And you don't have to be afraid to titrate this up as needed, particularly if you're finding that you need to be at a higher FiO2. Going up on your PEEP a little bit might be able to help you bring that down and avoid some oxygen toxicity. And like I was saying, since these patients now have a primary lung problem, you should anticipate that both of these are going to settle out at a pretty low level. If you're finding that the patient who you thought was an intubation only for mental status is needing high amounts of FiO2 or PEEP, you're going to want to consider what else might be going on here. And this could be a mechanical problem, like, for example, maybe you have a right main stem intubation, or perhaps there's more medically going on here than you suspect. So just keep that in mind. But these are a pretty good place to start. Now, for your ventilatory parameters, so you're off to a great start. You've picked your mode, you've picked your oxygenation parameters, so now we have ventilatory. So for the patient we're considering here, we don't need to compensate for a severe acidosis and try to match a really high respiratory rate. Setting the ventilator to a pretty physiologic rate of around 12 or so is probably going to be adequate to get the job done. And for tidal volume, you have some flexibility here too. So you're probably familiar with 6 to 8 ml per kg of ideal body weight, which is what we often talk about with ARDS. Then you've probably heard about higher, more traditional volumes as well. So these patients, they don't have, the ones we're discussing here, do not have ARDS or an acute lung injury. So we're not going to have to go to a very lung protective strategy with very low tidal volumes. But you also don't want to go crazy either. So we don't need to set the tidal volume up to 15 because then we're probably going to cause damage, but we also don't need to go all the way down to 6 either. You can probably start at 8 initially. And then after that, as you can titrate based on the patient's end tidal or their PCO2 on gases, however you determine that you're going to monitor. And then if you find that your patient is becoming hypercapnic and you're set at the lower end in terms of respiratory rate or tidal volume, you can go up a little bit. And alternately, if they're becoming uh, alkalotic from a respiratory reason, you could back off the other way. So a couple of key points here. So remember, we're talking about ventilating the patient intubated purely for mental status without underlying respiratory pathology. So the two modes that I would recommend keeping in mind are going to be assist control and SIMV. And then remember, your parameters can be split into oxygenation and ventilation. For oxygenation, start them with 100% FiO2 and PEEP, and then and PEEP of 5, and then once you've kind of recovered from that immediate post-intubation period, you can start weaning down your FiO2. And you can go up on your PEEP some too, especially if it's going to help you decrease your FiO2 more. And then for ventilation, you can probably start at a rate around 12 and a tidal volume at around 8 ml per kg of ideal body weight. And then you can just titrate this based on your monitoring of the patient. So I hope this will help you choose your modes and settings more confidently the next time you encounter this scenario. Here are some references that I used to make this presentation. Like I said, I tried to keep it as simple as possible so that it's memorable and at the forefront of your mind. However, you can go much deeper into a lot of the topics mentioned just in this presentation alone. I think these references are a really good place to start. They certainly contain a lot more information. And if you're interested, I recommend checking them out. So I'll see you in the next presentation where we're going to talk about a few special cases.